Okay, good evening, everyone. My name is Scott Hinkle. I'm with Epic Dental Laboratory. Damian Moreno, the owner, has asked me to introduce and welcome everybody tonight to Epic and for this course that we're putting on, Innovations in Digital Occlusion. We want to thank you for joining us tonight. Most importantly, you should know that this is being recorded, so anything that you didn't get or you want to get, you'll be able to have later on to rewatch it. And if you've missed part of it, you'll be able to see all of it. So thank you for coming. We're excited to have you, and it's really promises to be a insightful and impactful evening. Let me introduce our speaker. I'm pleased to introduce Greg Kamyszek. He's the CEO of BioResearch. It is the leading company in dental technology for occlusal and jaw joint analysis. With all of his years of experience, more than 25 years experience, he has a deep commitment to advancing the science of occlusion. Greg has taught dentists in principles of measuring occlusion through force, timing, and balance worldwide. His expertise has been shared at prestigious learning institutes such as Penke, Dawson, and LVI, as well as many dental schools throughout the world. Greg is a part of our collaboration, and we're glad to have him. He's not here to dictate how you should treat malocclusion. Instead, he brings a wealth of knowledge with the tools and techniques used for diagnosis, measuring occlusion with precision. His work has been throughout to inform dentists how to make the best decisions when it comes to accurate and reliable data. We're so fortunate to have him tonight. And let me introduce Dr. Greg Kamyszek.
Thank you. I appreciate that.
Thanks for being here.
Oh, my pleasure. Pleasure. All right. Well, thank you very much for being here in person and joining us online. I am not a doctor. I appreciate that promotion, but my history is I started actually working for BioResearch as a salesman in 1994, in May of 94. I then took over their customer service department and have, systematically moved on and taken all the jobs that nobody else wants. And so now I'm the president of the company. As Scott said, what we do and what we're going to talk about tonight is how to measure the things that are important when you're trying to establish a stable occlusion or you're trying to improve an unstable occlusion. So I'm going to go through that. If there are specific questions as far as how different treatment philosophies address that, we are planning some follow-up courses where doctors will be coming, where we give courses in the different treatment philosophies. So we'll get to that, but I'm not going to be standing here saying this is a treatment that works or this is a treatment that doesn't. But what our company has always focused on is measurement of physiologic parameters that you can't see any other way in your practice. And so what we'll do is we'll just get started here right away. If people have questions, I don't want this to be a real formal thing. You can unmute yourself. You're welcome to ask a question. I should be able to hear it. If that doesn't work, feel free to email or text Scott Hinkle. He'll be here for the duration, and we'll get going. One of the other things that we do, I'm not going to really get into it, but we do actually carry a whole line of treatment lasers for soft tissue, pain healing, reduction of inflammation, intraoral surgery, that sort of thing. But tonight, what we're going to talk about is dental occlusion made easy. So I'm going to try and simplify this quite a bit. We're not going to get real in depth, but we have a whole host of courses that we can follow up with. As I said, I'm Greg Kamyszek. I am the CEO, co-owner. I run engineering now for BioResearch, run all of our quality stuff, and also handle our training at the office. I'm a father of two. We're based in Milwaukee, so I have to have a Harley Davidson. That's like state law pretty much in Wisconsin now. But I'm very happy to be here in Utah. This is absolutely gorgeous, looking up at the mountains and being able to hang out here and smell the mountain air. It's really great. So when we're talking about creating a stable dental occlusion or looking at a dental occlusion, I had the great pleasure of being able to work with Pete Dawson personally at the Dawson Academy in Florida. And in all of his books and in all of his philosophy, one of the things that he always pointed out was all occlusal analysis, because when we think occlusion, we think teeth, right? Right away, we think teeth. But his axiom was all occlusal analysis begins with the TM joint. And if you think about it, if you have a disc displacement, or if you have degenerative joint disease, or if you have inflammation in one of the discs, right, that's going to change your bite, because if you change the position of the condyle, that's going to change the way the teeth come together. Okay. If that gets worse or gets better, that's also going to change your bite. So the first thing we're going to talk about is how to either confirm there's a stabilized TM joint during function, or how to, through changing jaw position, improve that and document that you've done. Then what we're going to do is we're going to get directly into measuring the actual interdigitation of the teeth and looking at what we can do there. So that's going to be the course for the night. And really the whole idea here is to help you see the road ahead, to see if it's something that's going to be smooth sailing or if it's going to be really difficult and maybe something you want to take a little bit slower approach towards. Now, when we look at this topic of TMJ or TMD, this is not going to be a craniofacial pain course. That's not what we're trying to accomplish here. What we're talking today about is everyday bread and butter dentistry, restorative dentistry, implants, that sort of thing. Okay. We can go a lot deeper into this, but the physiology is impacted by your dentistry, right? If you add a crowning, or if you do a bridge, or you do a full arch, or you do an implant, that changes the physiologic landscape. For those clinicians that are in that TMD, TMJ world, there's really four main philosophies that doctors follow. There's the tooth-based or gnatologic philosophy. We've got to balance the bite, and that gets rid of craniofacial pain. The muscle-based or neuromuscular-based philosophy. The joint-based or CR with Dawson, Pankey, Spear, etc. And then we also have the psychosocial group, people that think that TMD, craniofacial pain, headaches is all a psychological problem, or predominantly a psychological problem. The way that we look at it is my company designs and develops tools so you know how is the joint functioning, how are the muscles functioning, how are the teeth coming together. We're not in the psychology business, but if you're in chronic pain, that's an important thing, right? To be able to deal with that kind of stress, that kind of anxiety. So these are the things that we work with, and these are some of the people that we work with. We work with everybody who is interested in craniofacial physiology, regardless of their treatment philosophy. So what we're going to focus on first is the temporomandibular joint. So real fast anatomy refresher, right? We have the condyle, we have the fossa. Those are the bony structures. Then we have the articular disc. What's interesting about this joint is the disc is attached to the superior head of the pterygoid and the condyle to the inferior head of the pterygoid. So when you open and that pterygoid contracts, it pulls that disc and condyle down and forward together. So they move as one. Okay. Now, if we take a look at this image, you can see that if that disc was anteriorly displaced, right? If that disc slides forward, the superior head of the pterygoid is shortened, right? If that disc goes forward, that piece that it's attached to is going to shorten up a little bit. If you shorten a muscle, it goes into contraction. Okay. What's going to happen to the condyle? The condyle, with the disc not between it and the fossa, is going to move up and back. So what does that do, considering the condyle is part of the mandible? What does that do to the teeth? So now all of a sudden, just by moving one piece, the disc, we've impacted the muscles and we've impacted the occlusion. Okay. Same idea. If we change the teeth, we change vertical dimension. You know, right now I'm going through maxillary expansion orthodontics, a very high palate snoring, sleep apnea, that sort of thing. And I've had great results with it. But orthodontics is a full mouth reconstruction. I'll never have the vertical lateral AP mandibular to maxillary relationship I did a year and a half ago. Right now, this is all my orthodontist's creation. Right? We do full arch dentistry. We do quadrant dentistry. We've just changed that dynamic forever. Okay. We'll get into that in just a little bit. When should you look at the TM joint? When should you really perform an analysis? The diehards say all the time, every day, you know, make sure that you're always on top of it. What we recommend is obviously if there's pain, right? If they're having any sort of functional dentist difficulty, but the other big one is dentistry. If you're changing or stressing the mandibular maxillary relationship, that's when you should take a good serious look at the TM joint. Okay. So if we're trying to analyze TM joint function, there's a lot of different ways that we can do it. You could do MRI, you could do CBCT. Those are static images that you have to interpret or someone else interprets for you. Okay. You can ask the patient. You can palpate. You can use your fingers, feel the pops and clicks. There's a device out there. It's like $200 called the Doppler that gives off a little bit of a vibration, and you hear a playback of that echo of the condyle and the disc moving, right? You can use auscultation, which is just a stethoscope, and listen to the disc, okay? With these methods, what all of these methods are is they're subjective, right? Because you have to interpret them. So what ends up happening is if we look at the research on these subjective methods, they're all 40–50% accurate, sensitive, and specific, right? The big thing in this slide that gets me is the 14% inter-observer agreement. And what I like to demonstrate is if you're listening to a jaw joint and when the patient opens, you hear, and they close and you hear, just that's what you heard. And you write that down in your notes, all right? Write down its amplitude, its duration, its frequency, where it occurred in the opening and close. Now you have a record. But if you looked at his notes, would he write the same thing you do? Or would she write the same thing you do? You know what I mean? Or would any of you write the same thing anybody else did? Now we fast forward 6 months, they're back in for recall. Hey, how's that click that you were worried about? Well, let me take a listen to it. And now it sounds like on open and on close. And you look at your notes. How do you remember what it was? It was 6 months ago. You know, all of the, kids late for school and other patients and everything going on in your life. Those kind of subjective records really don't give you a strong handle on what's going on in the TM joint. The research that's been done on the device we created, joint vibration analysis, nothing is 100% in these research articles. We just happen to get all of the pathologies, but the sensitivity and specificity, not just for normal versus abnormal, but inflammation, disc displacement, medial or anterior disc displacement, early and late degenerative is very high, always in the high 90s. So JVA is very simple. This is only going to be about 20 minutes of the presentation. We're going to do a little bit of it, but it's completely non-invasive, accurate and objective, and it works on a super simple principle of motion and friction, okay? When we think of TM joint anatomy, you've got the condyle, which is articulating bone. You have the lower joint compartment, synovial fluid. You have the disc. Then you have the upper joint compartment, again, synovial fluid and smooth articulating bone. When that works, like any good joint, I still have 2 or 3 good joints left in my body. Those joints are quiet, right? But when a joint starts to break down, when it starts to have a pathology, it starts to create a noise. And what we found in our research in the late 80s, early 90s was if we recorded with the right sensor, we could determine the difference between fluid, disc, and bone. And the whole reason is what we're doing is we're recording the amplitude or the strength of the vibration, but then we look at the frequency. And if you think about it, synovial fluid is less dense than the disc, and the disc is less dense than the bone. So if you take a hammer and you hit your mattress at home, it'll go thump. It'll be a low frequency sound. If you take that hammer and hit a steel light post, it goes ping. It makes a high frequency sound. So what we were able to do is we worked with several oral surgeons that were doing open joint surgery. And we would actually take a JVA on this patient that was scheduled for open joint surgery. The surgeon would cut them open and go, oh, that's a displaced disc, or this is a medially displaced disc, or there's a lot of inflammation, but other than that, everything's in the right spot, or degeneration, etc. We were then able to break down the numbers, and we'll go through this flow chart that we've come up with that helps you categorize what's going on in the TM joint very quickly. But basically, normal range of motion, silent joints are normal, right? What I'm going to do, instead of playing just a silly video on how to do this, I'm going to show you the way that JVA works is we just take this little amplifier, plugs into any USB computer that you've got, you add the software. We take our headset, and it just goes right over the back of the head, over the TM joint, like this, so that you have the sensors on the temporomandibular joint. You're going to measure the patient's maximum opening. How far do they open, right? My maximum opening is 52 millimeters. And the other thing you're going to look at is when they open, do they deviate off to the right or off to the left? Now, we're not looking for a mandibular or a maxillary, no, sorry, mandibular deviation. Does their jaw go out and then back to center? That's a deviation. That we don't worry about. What we're looking for is when they open, is their chin off to one side at maximum opening? Okay, because what that'll indicate to us is the disc could be displaced on one side and you have normal function on the other. And if you have disc displacement without reduction, or the disc doesn't go back to the normal position, that one condyle gets stuck and the other just keeps moving. And you end up opening like this, okay? A deviation is either a muscle issue or a joint issue that slows down one of the condyles, but then it catches up, okay? So in order to take the data, all we're going to do is click this button, JVA Quick, and right here I've already entered my maximum opening. I do not deflect at maximum opening. I have a nice straight opening and closing, and we say okay. Now, the top line here is vibrations from the right joint. The bottom line here are vibrations from the left joint. And you'll notice this green line going up and down, goes up and down in time with this animation opening and closing. Okay, so this is just our basic quick setup. So this green line is going to be open and close and open and close when I open and close along with the animation, which is just what I'll do. So we just go like this. All right, so what we have is this is what a normal joint vibration analysis trace looks like. Okay, so what we have is this green line all the way at the top. My teeth are together, and when my teeth came together, they made this vibration. This is my teeth capping on the right and on the left at the exact same time here at the peak. Okay, then I opened and I closed, and there's another tooth contact. So if there were a vibration here, that would be a right-sided opening vibration. If there was a vibration here, it'd be right-sided closing vibration. This little blip that occasionally occurs, late opening on my left-hand side, was 2004. I thought I was better at Taekwondo than I really was, and I subsequently quit. But I got a kick to the lower right side of my jaw, and it jammed everything back. And I had this huge click, which over a period of about 6 months just slowly went away. Okay, so it was something that I wasn't permanently damaged, but it was something that was going wrong in my joint, and it has left a little bit of a residue, but by and large, this is normal. So this is what you want to look at when we go through just the examples of how do you look at JVA, how do you use JVA. The normal is tooth contact when the green line goes all the way up and nothing in between with a normal range of motion. It's that simple, okay? All right, so here we have a trace that's very much like that. And this is why, I don't know if the people listening can hear this.
The distal thin part of the disc is consistently lying in between.
But you see how the condyle and the disc move together as the condyle rotates and translates and the disc moves down.
In the upper compartment.
And so what that does is that creates a very silent joint. There's just no sounds that come from it. Okay. Now that we know what a normal joint vibration analysis trace looks like, you've had 7 minutes of training in JVA interpretation, right? Here's another joint vibration analysis trace. And if we take a look at the right side, this green line goes down and then it comes up and then it goes down and then it comes up. This trace, just this raw trace, is this normal or not normal? All right, does anybody here think it's normal? Okay, so remember I said we had 14% inter-observer agreement with the subjective methods. Here we have 100% agreement. This isn't right. We may not know what it is yet, but there is something going on in this joint and I've documented. Okay, now we have a lot of clients who use it specifically for this reason and this reason only. I do restorative dentistry. I'm not a TM joint person. I'm going to make you gorgeous. You have a joint problem. This is my doctor friend who handles TMJ stuff. I'm going to refer you out to her or to him. I'm going to continue to do your dentistry. But what you've done is you're now not screwing around with, and that's why I say I'm not trying to make anybody TMD or craniofacial pain specialists. There's nothing wrong with the kind of practice you want to have, right? Some want to focus on implants, some want to focus on cosmetics, some want to focus on peds, some want to focus on pain. You do what you want to do. But what this does is it allows you, before you even start changing anything, to identify, A, there's a problem, prove there's a problem, and show the patient there's a problem, okay? Now, what this one in particular is if you look at this waveform, the thing I'm going to ask you, see this vertical cursor right here? Where that vertical cursor is blown up down in the lower left-hand window called the zoom window. And you'll see it shows the actual pressure wave of the vibration. Now, this pressure wave is created by the disc being off the condyle, and when the patient is opening, it's popping into place or reducing. If you've heard the term, and I don't mean it, I'm sure you probably know this, but when a joint reduces, it means it was out of position and now it's going into the correct position. Okay, so we have our condyle. The disc should be here, but it is displaced. Then when the patient opens, it pops into place. There's our opening vibration. And then when you close, at some point, it's popping off again. So that's exactly what we're going to see right here. This disc is displaced anteriorly, and there it just reduced. Now the disc is in the right position. Okay. The whole idea behind splint therapy for the TM joint is to get the disc to reduce and put something between their teeth so they stop closing right there. Now, when they open, the disc is in the right position. And they all open and close, and hopefully it will not displace. You know, a lot of that depends on how long this has been going on, right? But one of the things that we'll see is orthodontic clients or sleep dentistry clients. I'm going to put a snoring appliance in that's going to open you up and bring you forward so you can breathe better at night, right? And they'll just take a leaf gauge and say, come forward 2 millimeters. I'm going to take a bite there. Well, if the disc is anteriorly displaced, and we see this all the time, and you don't open the jaw up enough, you don't bring that mandible down and forward and get it underneath the disc, you just bring it forward, all you end up doing is actually tightening the pressure on that disc. So when you open, it goes, and the patient's like, this is way worse. What we can do is in the bite registration phase, just taking the bite, open and close into that little strip of polyvinyl siloxane. Open and close. Take another JVA. Is this better or worse? Oh, it's way worse. Okay, that's not my sleep position, because the number one reason people stop wearing snoring appliances is joint or muscle pain, right? My particular case, the first time I wore a snoring appliance was mid-2000s, and the doctor that made it for me, it did open me up. I was able to breathe. I was a semi-pro snorer all my life. I mean, really loud snore. My college roommate still wears shooting earmuffs to sleep because he got used to doing that when we were in college in the dorm. I was able to breathe for the first time, had REM rebound. That night was like an 8-hour color movie. It was awesome. I mean, it really was awesome. The alarm went off. I heard it. I'm like, this thing is the greatest ever. 4 days later, I couldn't open my mouth. And the whole thing is that it was just putting too much stress on my TM joint. I never told that doctor that I stopped wearing it. But a year later, finally, I went back, got another one, and told them what had happened. And they said, well, we're going to open you up a little bit more, and we're going to test you. Right. And so then that snoring appliance I wore until about 2 years ago, when I just got too old, and an anterior repositioning appliance made me incredibly class 3. I didn't really care about that. I wasn't worried about the aesthetics of it, but it stopped working. And I was still snoring with the appliance in, which is why now I'm in maxillary expansion ortho to kind of bring everything out, open up that airway. But this is an anterior disc displacement. So we can see, number one, there is a problem. And number two, we can see what that problem is with the numbers, and we'll go through that in just a bit. Now, one thing to think about is if you have this kind of a pathology where you have a displaced disc on one side and the other is normal, what happens is one condyle, the disc pops on and that condyle vibrates forward and back. Okay. The entire mandible is a bone going to the other condyle. If this one vibrates forward and back, the opposite one just rotates a tiny little bit. So when you look at this actual trace, we see a big vibration on the right, but there's almost no carryover to the other side. Okay. And this is an anterior disc displacement. Now we're going to take a look at this trace. Looking up here at this sweep view, is this normal or not normal? Clearly not normal, right? This vibration, though, if you look, there's a vibration that occurs in the right and a vibration that occurs in the left. What this is this is actually a medial disc displacement with reduction. So if we look at how this actually functions, the disc is reduced, it's in the right place, and now it's slipping medially. Okay. It's nice we have this during degree. Now, the reason that that happens is this is that zoom view blown up. What happens is when we have a medial displacement, the disc is displaced medially. When you open, it pops this way and the condyle vibrates right left. One bone to this condyle. When this condyle goes right, this condyle goes right. When this one goes left, this one goes left. They go together because the jaw is one bone. Well, our sensors test pressure 2,000 times a second at the exact same time. So you'll see the pressure waves here on this left one go positive, negative, positive, whereas the right one goes negative, positive, negative. Okay. So what that tells me is this one started first, and then just milliseconds later, this one kicked in. This is a left-sided medial disc displacement, and this is just a carrier. So there's nothing wrong with the right side joint. What's really interesting is very often patients will say, yeah, my right joint clicks. And then when we actually measure it, the left side, or the side they think is fine, is first and bigger. So we're able to dial this in and see exactly what it is. Okay. And then lastly, we have this one. I'm not going to go through the exercise. We all know this is not a normal TM joint function. There's a lot of vibration going on. But if we look at the waveform, this is not like the ones we've seen before. This is very long duration. I'm actually going to back up just a bit. You see this space here between the up and down strokes, how there's a lot of vertical space. There's a lot rather horizontal space between the up and down strokes. Here, we've got these really highly compressed, long duration vibrations, okay? What this is the disc is now completely displaced or perforated, and we've got bone rubbing on bone, okay? So there is no reduction. The disc is in great shape. It's just curled up in front of the condyle here and no longer attached to the retrodiscal tissue. So really what we have is just bone rubbing on bone, right? Now you can have this in a perforation, which can happen in an accident. You can have this over, long periods of popping and clicking for life. But what I'm trying to get across is that what JVA allows you to do is to identify normal functioning TM joints and identify abnormal objectively and permanently, because you just saved the trace, right? Now you have a record. I didn't do this. I didn't create this. If you want to go that next step, if you're doing any TMD or if you're doing, any sort of splint therapy or any sort of restorative sleep dentistry where you'd like to know, is what I'm doing making that better too, right? One of the things that we find, I talked about with the snoring and sleep apnea appliances, how they can make the disc worse. Well, a lot of times though, bringing that jaw down and forward makes the joint better. So not only am I allowing you to breathe better at night, but that disc displacement you had is more stable in this position. And what is not uncommon is for the patients to say, well, then why don't we just make it there instead of me having to wear this all the time? I'm not trying to say that you just jump every sleep person into full mouth, but that is an option. I mean, that's the option I'm taking. I'm taking the mode of doing ortho to replace my snoring appliance. Okay. But the other point that I really make is each pathology has a unique signature that is easily identifiable. Now, the way that we do that is we have, and I'll just pass this out. We'll email this to everybody who's watching online. But what we did in the 80s and 90s, late 80s, early 90s, was I had mentioned that surgical research, where what we were doing was taking JVAs on patients going in for open joint surgery. We took all of the normals and put them in a pile. We took all of the different pathologies and put them in the pile, and then we compared the numbers. And what we were able to do was to create an artificial intelligence software that really just ran through this flow chart. Okay. And so I'll try and explain that here in a bit. But basically what we're going to do, let me get out of this and we'll actually take a look at patient. Let's go. This was a patient that I saw in April. So the patient came in and this was their JVA. Okay. Clearly not normal. And what we're going to do is I'm just going to take my cursor here and I'm going to go to this big opening click and I'm going to mark it. X marks the spot. And then I'm going to go into the next opening and closing phase and I'm going to mark that one. And the next one. Now on this flow chart, what we notice when I mark these vibrations, all of a sudden in the upper right, these numbers show up. Okay. The total integral is the power of the vibration in newtons per square meter, how much energy. Okay. So on this flow chart, the very first question is, what is the total integral? Is it 0 to 20, 20 to 80, 80 to 300, or 300 and greater? Right. And if we take a look here, the left is 74, the right is 108. Let's take a look. What's that? You need another one? Oh, that's what they did. Oh, they printed the front and back. Sorry. This is what you should have. There you go. Yeah, no worries. Let's spread those out. Thank you. All right, so let's take a look at this left joint. The total power is 74. 74 fits between 20 and 80. So now we're no longer looking at these portions of the flow chart or the bottom ones. Okay, so all of these are gone. So then the next question is, what is the patient's maximum opening? This patient's maximum opening is 50. That fits between 40 and 70. What is the energy greater than 300 hertz? That matters because we found disc resonates below 300 hertz, bone resonates above. So the whole question for 300 is this soft tissue or is this hard tissue? Well, the energy over 300 hertz for the left joint is 4. That fits here in this 3+ category. Well, what is the ratio of 300 high to 300 low? The ratio is 0.06. That fits between 0 and 0.2. So this is a partial disc displacement, and other people call it ligament laxity, right? Those are just two different terms. But essentially, it's either a partial disc displacement or the disc is just sliding on the condyle a little bit. It's loose, okay? If we look at the right one at 108, that's between 80 and 300. Our maximum opening still at 50. The ratio on the right joint is 0.17. That fits between 0 and 0.3. And is this late opening or is this chronic adapted disc displacement with reduction? And with this patient, this was actually not late opening. So this was about midway through opening. And that's what we had. Now, so what we have with this patient is a partial disc displacement on the right side, the left side, and a complete displacement on the left. Now we were at a training seminar and one of the instructors said, well, here, let me put you in the right position. And with his hands, kind of aligned the teeth and said, yep, that's where I need you to be, open and close, and we shot a bite. So we shot that bite, and this is what we ended up with. And that was our second appliance here. So we went from 74 and 108. We knocked that vibration down to 16 and 22, just total power. Now, if we go through this flow chart, the left is going to be within normal limits and the right is just outside of normal limits. And the patient said, I don't think that's quite right. Like, it's better. So we just said, well, let's just put another wash of silicone on the bite and just don't close quite that far. And really all we did was, let's open you another 0.5 millimeter. And so then we went and took a JVA again. And this is where we ended up building the demand appliance. These were the vibrations. Now, she couldn't hit her teeth very hard, so you don't see those tooth contacts because she had the bite registration material between. But opening and closing all the way, we're down to 4 and 8.2, and she had a full range of motion. So we're fairly confident that this position is healthy for the joint, right? And if it's aesthetically pleasing, that's a great position. So if you're going to do full arch dentistry or implants or any appliance, you now have the ability to say, do I want to do it in a position that's going to create this joint function, or this joint function? And if you can't find a place that where the joint will function normally, wouldn't say it's common, but it's not unheard of. I just can't get a place. This joint's really chewed up. Is it better to know that in the beginning and objectively document it? Or is it better to find that out once everything's seated and you're like, I hope you're feeling great. Actually, we need to talk, right? So that's the whole concept of JVA. So I'm not trying to push any particular treatment philosophy, but this is simply a tool that allows you to know, is the joint functioning properly at the current level? And that's it.
So when you're taking, once you start it, is it very much opening two millimeters?
That is where the different treatment philosophies come in. Like, how do you actually take a bite, right? And there's the centric relation philosophy. When I first started, centric relation was jaw up and back as far as you could go, rotating position, take that bite. That, over a period of about 10 years, evolved to uppermost, midmost. The condyles going up and in the middle, not up and back. Because what they really started to realize is if we push up and back, you can kick that disc out, right? There are groups that will do things like massage or TENS therapy or laser therapy to relax the muscles. Because if your joint is screwed up, my girlfriend is a very competitive tennis player and is going to need a hip replacement. Her hip doesn't hurt at all. Her lower back hurts and her legs hurt because her lower back and legs are supporting the hip, right? So she has muscle pain. Muscles are not her problem. Her problem is that disc, or rather is the joint, right? So what the neuromuscular philosophies will do, really in a nutshell, I'm not doing it justice, I'm not trying to teach it, but let's relax the craniofacial muscles so they're no longer bracing, so there's no engrams. Let the jaw fall where it wants, and then take a bite at a vertical dimension that makes sense. That is within aesthetic, realistic, we're not going to have a CEJ to CEJ of 30, right? But try and find something in there and then test again. Now, the neuromuscular approach, some of them use JVA, most of them use electromyography because their approach, they're interested in what are the muscles doing, right? And we have that. What we do, I don't want, and Scott and I have known each other for 25 years. We didn't want this to be like salesy, but we intentionally created the BioPack to be a kit. What do you want to know? I want to know how the joint's functioning. Okay, we have JVA. I want to know how the muscles are functioning. We have an EMG. I want to know occlusion. We have a device to measure that. And Scott has a question?
So people online aren't hearing the questions here. So
Oh,
you could repeat
the questions. Absolutely. Yeah, the microphone's pointing right at me. Good point. Thank you. The question was, so how do you determine that bite? Is it just arbitrary? Right? And it can be. I had a TMD doctor who treated TMD, and he was very neuromuscular, and then he got very heavy into joints and things like that. After 40 years, he literally would say he does a TLG bite. And what he would do is lips together, have you move your jaw until he felt that looked good. And then he'd take a bite there. He's like, I just have a feel for it now, like what works. And he'd take the bite, take a JVA and go 70% better. Let's open a little bit. Then he'd play, right? So for us, from my perspective as a person who runs a company that makes a diagnostic aid, I don't care what your treatment is. You can give them a drug, take a JVA. You can open them 4 millimeters, take a JVA. You can try a laser. You can try a TENS unit. You can try a prayer. You can try stomping on their foot. If their JVA got better after you stomped on their foot, for that patient, it worked. Right?
Educators will use like an interior deprogram.
Oh, for sure. For sure. And there's a lot of arguments, you see this online all the time. The comment was a lot of doctors will use anterior deprogrammers, and that's true. And there's the argument, if you use an anterior deprogrammer and the disc is anteriorly displaced, that mandible's going to rotate and you're going to make it worse. Right? We have clients who agree with that. And we have clients who say that has never happened once in my practice, and I've used 1,000 anterior deprogrammers. As long as you have a JVA afterwards, it doesn't matter. You know what impact you've had. Okay. Now there's a capital investment to get JVA, yes, but there's no supplies, there's no anything. It's once you have it, it's free for as many times as you want to do it. So we just recommend to people just take as many as you can. There's no harm in just taking another one, right? All right. Let's go here. But essentially, that's the whole process of doing your diagnosis. Now, the other thing that I will add is that joint vibrate, you can do printout reports and things like that. We've got a whole bunch of software. Anything that you end up getting from us has all of the courses. We have in-person courses, online training, learning management system. We are very heavy into training. But what I want to really get across is that the beauty of something like this is that you don't have to know how to treat it, right? As a dentist, you're responsible for the health of the temporomandibular joint. You're responsible for the occlusion. You don't have to treat anything you don't want to or you aren't comfortable in treating. You can refer out, right? The key is, do you want to know or not? And the beauty is that having been with bioresearch for 30 years, we've never in 30 years had a client use our equipment and lose in a lawsuit because they can prove this is what I did. And I made this decision because of this. Now, even if that was the wrong decisions happen in medicine, and dentistry is medicine all the time. This is what the heart rate was. This is what the blood pressure was. So I did this. Did it go well? No, it didn't go well. But at least I had a reason. Do you know what I mean? I made a logical choice and I didn't neglect looking, right? And that's really what I'm trying to get across here. Okay. Now, any questions on JVA, TM joints, that sort of thing, what its application is in dentistry? For those online, I'm not sure we can hear you. Somebody's talking, but you're not coming through. If you have a question, if you could text it or email it to Scott. Do we want to take one? Anybody want to take a JVA and take a look at how their joint functions? You want to do that? All right, come on up here. Here's what we're going to do. I'm going to get out of here. You're going to take this chair. So you're going to go ahead and sit here. And what I'm going to have you do is actually look at that screen. Real quick, I'm going to grab. Now, what I'm using is actually my business card. But what we did is we just put the range of motion indicators on that. So all I'm going to do is take this little hook, put it in the lower incisors, and have you open as far as you can. Open wide, wide. Okay. That is a good 67 millimeter maximum opening. That's a good normal range of motion, right? Now, because his range of motion is 67, I don't even have to look and see if he deflects. He doesn't. Because for a 67 millimeter maximum opening, those condyles have to really come down. And if you only one was able to go, say, halfway, to get to 67, you'd have to rip the other one right out of your head, right? If there's a deflection to one side, you will always see a significantly reduced range of motion. When you open as wide as you can't go left, right. There really isn't any way to move because those condyles are already translated as far as they can. So what I'm going to do is I'm just going to click, we're going to take a JVA quick, and I am going to put 67 as your maximum opening and 0 for your deflection. And we say, okay. Now, what I want you to do, first we have to put the headset on. Very important. Sorry. This is the beginning step, right? So we're just gonna take this, hang this around your neck. You could turn that beep off if it annoys you. Now, all I'm doing is placing the sensors. You notice he's got a beard, putting the sensors right on that skin between the hairline and the ear so that we have the sensors in touch with the skin so that we can pick up the vibrations. Now, what I'm going to ask the patient to do is in time with this animation, when she opens, I want you to open. When she closes, I want you to close. I want you to close hard enough that you hear your teeth tap in your head. Okay? So whenever you're ready, we're going to go wide, tap, wide, tap, wide, tap, tap, wide, tap, tap, wide, tap, wide, tap, wide, tap. Okay, so taking a look at this, normal or not normal?
I won't be affected.
No. Yeah, right. No, but what we see here is here we've got the green line coming up. That's your teeth hitting here and here. But then as you start to open, we have this vibration. You got a little, you just have some little bits of stuff going on. That's certainly a bigger, oh, you know what? That's actually a closing vibration. This is your teeth. You open and there's an opening vibration and then you close. Here's your teeth, closing click, teeth, closing click, teeth. Make sense? Okay. So what I'm going to do first of all is I'm going to save this. And we're going to call this initial exam. And do me a favor, just spell your last name for me.
AJ.
We're going to quit and review. And we're going to take this cursor here. That is his teeth hitting. And I'm just scrolling through here. And what I'm doing is I'm looking in this lower left-hand side. There's a late opening click. Now I could mark that one. This is the one that's interesting to me. And that is your default speaker is changed to speakers. Okay, so if we are to take a look at the flow chart. Oh, they turned off the TV. Hold on. We're having a little technical difficulty here, folks. What I might have done, the remote controls right there, I may have bumped it with the JVA system. All right, here we go. Now we're doing it right? Yeah, okay. All right, so let's take a look at the flow chart here. This vibration down here on the left, what I can tell you is this is soft tissue. This might even be inflammation. This might even be fluid. You notice when we had hard tissue, it was all real jagged, horizontally compressed. When I showed you those disc displacements, they went up to a point and then down, but there was some space. When you see this really smooth rolling wave, that's very often fluid. Okay. So, and we look at the ratio that left, power is 39, but the power of that vibration is 34.9. Only 0.9 of that is above 300 hertz. So this is very, very, very soft tissue vibration. On the right side, we're at 82 with the ratio being 0.02. So again, out of this 82.2, 80.6 is below 300 hertz or soft tissue, the disc or fluid, right? only 1.6 is hard tissue. So neither of these are perforation, degeneration, arthritis, any of that stuff, right? On the right, you have the disc moving, and on the left, you likely have fluid moving, okay? So let's treat it. So bite, let me see your teeth. Okay, you've got a decent overbite and overjet. Come forward, slide incisal edge to incisal edge, right there. Okay, so what I did is I just had him go, I can't because I'm so class 3, but I had him go incisal edge to incisal edge. By doing that, what did I do? I opened him, I brought him forward. Now, I'm not saying that's the treatment. What I'm saying is you could do any treatment. What if the person said, I think that's going to fix you, right? Or the doctor, or you thought that might. So what we're going to have you do is start edge to edge like that and open and close to that position, okay? So now we are incisal edge to incisal edge. We're going to have you just go wide, tap, wide, tap, wide, tap, 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 wide, tap. Okay. Now, just subjectively looking at this, does this look better or worse to you guys? Well, let's not call that a follow-up. Let's call that with orthotic. So if this is where we were going to place the splint, or if this is where we we're going to finish the bite or do the restoration, we think this is probably a little bit better. But what we're able to do is go here into the review mode. That's his teeth hitting. There's that closing vibration we looked at before, right there, there, and there. And so his initial exam was 34 and 82. And now incisal edge, and you really don't have a deep bite or anything, right? Incisal edge to incisal edge, we brought that 34 and 82 down to 9.2 and 21. So we've been able to get that friction reduced within that joint. Okay, now 21 is just
different when you open and close into different positions.
I was trying
being asked, does it feel different?
No, I honestly can't tell right now.
Right. Yeah. So one of the great things here is if you wanted to, I mean, this is just better. Boom, done. I don't want to screw around. I'm not a TMJ doctor. I don't want to get a heavy into pain or any of that sort of stuff. This is where I want to do the restorations. You've got a little bit of vibration there. We want to keep an eye on that. We have the tool to keep an eye on. Okay. If you wanted to, you could say, well, what if we added a little more on the right? Or brought you forward, opened you a little more, within the realm of reality. But now you can, for lack of a better term, play with treatments, test treatments live. What position are we going to use for you? Okay. Thank you for playing. Take that, take this. Now, for the sake of time, we're going to keep going. But if you want to do this after fact, we'll get going. But I know everybody's busy and we've only got 2 hours here, and I was told keep it tight. All right. So that is JVA. So now what we're going to do, what we just finished talking about was the beginning of the stomatognathic system. Do we have a stable temporomandibular joint? If we do, great. If we don't, can we improve it? Now we're going to do our restorative dentistry. We're going to do our orthodontics. We're going to do our all-on-X implants. We're going to do whatever it is you do in dentistry. When you're done, now we have this whole new occlusion. Right? We have this whole new force timing and balance of the way the teeth come together. No longer talking about the joint, we're talking about how the teeth interdigitate. Okay. And what has been around for a long time is the T-Scan system. This is the latest one. This is the T-Scan Novus. BioResearch, we didn't make this. This is a device that we're the North American distributor for. So what it does is it allows you to record force, timing, and balance of the dental occlusion. And it's real simple. I mean, you have a sensor here, and I'll pass these around for you to look at. This is the sensor that we've developed that you bite on, a handle that you plug it into, and software that does the analysis. Not going to go through this real heavy, but this is just showing that we've done our due diligence in regulatory, and that every sensor records the same as every other sensor, that they don't get stressed out. This company, TechScan, that designs this, they're not terribly active in dentistry. That's what they have us for, but they make everything. They've got T-Scan sensors for saddles on racing horses, for Dr. Scholl's pick your right implant. I don't know if you have CVS or Costco or Walmart here or Walgreens. They have all of them, right? They have that little stand, and you stand on it, and it shows the pressure points on your feet and tells you which insole to buy. That's this sensor. And all it is pressure on both sides gets recorded. Okay. So what happened, actually dentistry is where this company started. They made this and then realized there's way more money in industry than there is in dentistry, right? But that's fantastic. I mean, from motors to suspension springs to car doors, they've got all sorts of stuff. What we're going to talk about is using it in everyday patient exams, looking at painful contacts, orthodontics, prosthetics, and any really prosthetic case finishing. I'm going to get into a little bit the cold tooth hypersensitivity, because using this for that, cold and tooth sensitivity is a $1 billion a year industry. And the number of cases where they have cold sensitivity, and in looking at specific contacts or specific types of contacts and getting rid of them, the majority of the time resolution is almost immediate. And it's really kind of exciting to see that. I have a good friend of mine who had migraines since the age of 14, and weekly migraines that were pretty debilitating, but like a level 3 to 4 headache every single day of her life, starting at age 14. 14 was ortho. So once she got this new, not correlation and causation, not saying that orthodontist caused it, but same year she got ortho, all of a sudden she started getting the headaches. All of a sudden she had to drink with a straw, everything that was even cool. And she didn't drink with a straw like a normal person. She drank with the straw on the back of her tongue. She literally put that straw way up in her mouth, because there's no way this cold liquid is touching her teeth. And we went, looked that she had some discluding contacts when she would try to slide right or slide left that would create some problems. Zip, 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 got rid of them. Migraines went away, and tooth sensitivity went away almost immediately. Like that day, like it freaked her out. She was like, because what we actually do is give you a glass of ice water, pour it into your mouth, swish it to a count of 10. How painful is that on a scale of 1 to 10? Because it should be like a 2. Like, that's really cold. But for her, it was, why did you make me do that? Now I'm gonna have a migraine for the rest of the day. And she was really mad at me. And then we went through and we did the adjustments, and the dentist, Ben Sutter, said, here, do the ice water swish. And she does it, and she went, I can feel it a little on like here. And he's like, okay, we'll get dealing with that. And then all of a sudden you just saw her go, what the? Wait a minute. No, it's like, it was really kind of exciting. So that, to me, that's a really exciting area. And then TMD, treatment without splints or appliance, and any natural tooth occlusion adjustments. Again, I don't want this to be salesy, so I'm not going to get into how this benefits the patient, but it's cool and they get it. When the patient sees these graphs, you don't, just like we did with joint vibration analysis, where I said you've been trained for 7 minutes Is this normal or not normal? And everybody knew it wasn't normal. Patients intuitively get this stuff, right? And you're looking and you're showing and you're sharing and you're educating. And that is so much of being a dentist, is to be able to show your patients what it is you see and what it is you're trying to do. So I'm going to skip that, but what we're doing here is really trying to measure the occlusal outcome and to have fewer post-operative bite adjustment visits, minimize implant complications. We'll go into some of the research on that. This is huge, to reduce implant part breakage, screw loosenings, less porcelain chipping, and less TMD problems. Now, for these presentations, I used to have a lot of research, like citing this case, citing that case, citing this case. And really what I found is most dentists are doers rather than I want to read all the research. If you want to read the research, email me, let me know today, or email me at gregk@bioresearchinc.com. And we will bury you in the research. And I don't mean that in a negative way, but I mean, we have a ton of research over the past 3 decades on this technology. And it really, what questions you have has been covered in the research. If you want to control your prosthetic and implant outcomes, you have to choose the right contacts to treat. Now, choosing the right contacts is a big deal. If we take a look here, all we did was have the patient bite on the sensor. And you know what I'm going to do? I'm going to actually do a real quick demo for everyone on T-Scan on how it operates so that you know what you're looking at. All right, so this is the T-Scan handle and sensor. We also have a support that we use. I'm just going to take another sensor here. I think it helps if we can explain exactly how we get the data. Slide the sensor in. And close the system up. Now everything is actually controlled from the handle. We have a start and stop button and sensitivity up and down buttons right on the handle. Okay, so if I say I want to take a new recording, I hit the red button, and now we have a new recording screen. Okay, if you want to, our training goes into this in depth, but if you want to change this arch, you can. If you want to highlight, oh, number 4 is an implant or whatever, you can do that. If there's missing open or closed missing teeth, you can adjust this arch. You can also take a scan and drop the STL files right into the T-Scan here. And you'll see that in our slides. For doing demos like this, it's a lot of work for, I know what I'm looking at, right? But for case presentations, it's really exciting. All that we're going to do is have the patient bite on the sensor. There's a little notch here to line it up with midline. Everything we do is with patients sitting upright in good posture. Okay, not laying to the side, not laying back, right, but sitting upright. So we have the patient bite. Maximum intercuspation. Now my occlusion is going to be really screwy because I'm going through ortho, right? And my occlusion is different every single day. But what we're worried about is we're worried about sensitivity. For example, I'm squeezing as hard as I can right there with my fingers. And if I turn the sensitivity up, and again, I squeeze as hard as I can. Do you see how those colors got hotter and the pistons got higher? All right. The hotter the color, the higher the piston, the stronger the force. Okay. So I'm going to take that sensitivity back down just a bit. Because what T-Scan does is it records relative force. So what it's going to do is it doesn't record newtons per, square centimeter on that tooth. We do have a device that does that. But what this does is record relative force. So we want to get that sensitivity till we just see 2 to 3 pinks at maximum intercuspation. Now what I'm going to do is I'm going to start a recording. So what I did here, all right, so here's my arch and just explaining what you're seeing on the graph. The A is when I first started tooth contact. This black line is the pressure between on the sensor going from 0 to 100%, and then I relaxed and I let go. So that's what that black line is, right? The green line is the left side, the red line is the right side. You see I've got pretty decent balance there. And I have this little cursor that I can move right or left, or I can use these little sort of VCR controls and move forward a frame at a time and watch. We can actually watch this patient, this handsome patient, come into occlusion. And what's the first thing you notice that as I start to bite? You see this come up early? So if we take a look here, this is the way my teeth are loading as I come into occlusion. This black line is how much pressure in comparison to 100% bite force. I'm at about 30–40%, and this tooth is already all the way loaded up. All right. This is a premature contact. Now, I'm not going to do anything with this contact because it's going to be gone in a couple of days of ortho anyway, right? But if this was our occlusion, this is something we'd be looking at right away. Then as we move into maximum intercuspation, we start to see other teeth load. And I just want to give you a lay of the land here with the T-scan. What this system will do is it will compute the actual amount of force per tooth. Okay. So what we'd like to see on the molars is 10 or 12 on each tooth back here, getting down to the 6s and 8s in the premolars. And then for the anteriors, something like 2 to 4. We don't want teeth out of occlusion, but we don't want too much force on any particular tooth if they're natural teeth. So we look here and I've got 19% of my bite forces on 15, 19 on 14. That's a little high, but it's not terrible. I'm starting to get an semblance, but you can see from this, you can see from looking at me, I don't touch at all in the front. Like there's no contact going on there at all right now. Okay. So now what we're able to do is we're actually able to watch that patient come into occlusion. What is first tooth contact? You can see right over here on 14, that is very first tooth contact. What we'd like to see is as many contacts as possible come in and all stay relatively low force until they all seed at the same time. That's bilateral simultaneous contact and loading. That's what we'd like to see. Because if we see anything other than that, we're hitting something early and deflecting off of that, or that interference is going to cause the mandible to shift and create an entirely different bite. Once we get rid of that early interference, now we have a whole new bite. Well, we bite on the sensor again. So this is a process of looking what's hitting early, adjusting it, and then going back and taking another bite. And again, once you have this sensor, you can take 20, 30 bites and just keep recording over and over. Okay, I got rid of that early interference. Now what? Right? Until we get to a place where we're nice and balanced simultaneously. Did you have a question?
Maybe I missed this.
That's okay.
But if you guys were talking about joint correlate early interferences, but to get point in time, basically say, okay, what's causing that joint spasm? Or,
We have the
I mean, can you correlate the bite? I mean, it's like where your first point.
Sure.
You're on a reason buckle comes from 14.
Mhm.
Can you go over and say, okay, that's causing joint vibration over on the back?
If you're looking at the two of them, that's an interesting question. What the question was is, can you correlate what you see in JVA with what you see in T-scan? I would, yes, in a way you can. Okay, and what I mean by that is what I very first started out with was the concept that we have the temporomandibular joint, right? And quick review, which I know you know this, but we have the disc attached to the superior head of the pterygoid, the condyle attached to the inferior head of the pterygoid, the bone of the condyle attached to the teeth, right? If we change the disc, we change condylar position. If we change condylar position, we change the bite. If we change the bite, we change the muscles. If we change the muscles, we change the pterygoid, change the disc, change the disc. It's an interdependent, interrelated system. So yes, we do see that correlation. What you won't see is, oh, that tooth contact means anterior disc displacement or means something like that. But very often, one of the reasons I was really early on, hey, we don't tell you how to treat. Won't tell you whether you should do the nathologic treatment or CR-based treatment or neuromuscular-based treatment, is because number one, I'm not qualified, right? But number two, doctors will come in and they have their treatment philosophy, and this is the tool for the nathologic dentist. I want to know what the teeth are doing. What we found is they master that, but they still have patients who have problems. They go, what am I missing? Well, maybe you should look at the joint. Okay, then I'll do that. And it's really interesting. There are flat out some cases, and Dr. Ben Sutter, who gives a course that I'll talk about here in a little bit, has shown, because he uses JVA and he uses T-scan, that he'll look at a patient and say, well, you have a slight joint pathology, but you're really messed up occlusion wise. The joint is going to be splint therapy and take a while. Let's get the occlusion as good as we can without making massive changes to vertical dimensions, and then we'll go look at the joint. And if you get the nociceptive feedback from the teeth to stop the muscles in spasm, very often, remember when I said we would use a TENS unit or a laser to relax muscles to find that neuromuscular position? We'll see people using the T-scan get those muscles relaxed because they've gotten rid of those interferences. And then all of a sudden, this joint problem just goes away because the entire system felt, improved. So is that, that's blasphemy to the people who are joint primary, where the joint means everything and the teeth are after the fact. I don't get into those fights, right? The whole concept is I can adjust your occlusion today, or we could do splint therapy for a couple of weeks and see. What is your patient going to say? Do something while I'm here, and what is the cheapest and what is the quickest and what is the least invasive, right? And so, I mean, really, that's what I would ask. That's what I do ask for. That's what I have asked for my whole life. And so, when I went to go get maxillary expansion orthodontics, I came in because of what I do for a living, knowing my TM joints were normal, knowing that my craniofacial muscles are normal, but my bite was completely screwed up. My primary concern was airway. And so I wanted cheapest, fastest, quickest. Do you want to do ortho for 2 years at age 32? No, give me a splint. So I wore a splint while I'm asleep. Once that splint didn't work, okay, now I'm doing $16,000 maxillary expansion ortho with the photobiomodulation of the sutures to make sure that as a man of 56, things are moving the way they should, right? And I'm having great progress. But this allows you to select not just what is the cheapest, fastest thing I can get today, but what's the most cost-effective thing that will work, right? Good friend of Scott and mine is Dr. Chris Stevens, who doesn't lecture anymore. But one of the things he would always talk about in conjunction with this stuff is, do you remember him talking about giving up hope? Yeah. Giving up hope dentistry? It's like, well, I don't like this. Well, here, let's try this, go home, hope it works. And then 2 weeks later, so how are things? Didn't do anything, or it was great, or whatever. The whole concept here is we can test day one, what's going on, have an immediate impact, and know as they're leaving whether we achieved our objective or not. Okay. So let's keep looking at this. Did that answer your question? That yes, they are interrelated, but they're not directly correlated. So as we watch this occlusion come in, we can see that the left is loading first and loading early. All right. Now, the other thing that I want to point out in this screen is you see this little red and white square. That is the computed center of force icon. And once we get to about 15% pressure, it'll pop up and it'll compute where in the arch is the center of force at each recording. So if we get down here, we see that when I started biting, I had this big early contact and these 3 or 4 on the right-hand side, and my center of force was right in the middle. As my teeth started coming together, my center of force moves a little bit to the left, but it really kind of hovers around the center, but you see how far back it is. I had no anterior contact, so that center of force is going to be way back. All right. So what can we see? We can see when the teeth hit, in what order, how much pressure on each tooth, and what is the center of force. This little tail that's left behind by the center of force gives us a little bit of history. You started hitting over there, and then, you started hitting with the center of force over there, and then you move back over here. Okay. So if we take a look at these tooth contacts, does anyone want to wager where the highest force is on what we're looking at here? And how much? Because Scott's going to put my money up, right?
Yes.
Okay.
But
But what you're able to do now is in the mouth, again, with paper, look at what's going on in the mouth, but correlate it to what you see on the screen. Okay. Now, one of the things that's really interesting is I have heard all the different descriptions of what a donut looking mark means, or what a little dot means, or what a little line means, or what all of these different things that you'll see intraorally. When we look at actually measuring force, and what we've done is we've actually taken teeth and taken models and put them on a press and put known forces onto them and mark it. And we get the donuts, and we get the lines, and we get the streaks, and we get the missing spots, and we get all of the things that people say, oh, that means heavy. Oh, that means light. But we know that there isn't any actual direct correlation to what the paper does. What this does is it shows you that at some point there was contact there, strong enough to leave some ink. And that's all it tells you. And all of the research is clear on that. So if we're looking here, what is it exactly that we're looking at? So, when I look at this, I don't see that. Okay. Again, I'm not a dentist. Paper marks can look similar, but there isn't enough to really show you, looking in here, that this is actually creating that sort of a force. So now what you're able to do is to actually look and see how much force and in what order you have, and you add that to what you're seeing within the mouth. And so what I find really interesting is that, we've got these implant problems, and the one thing that we're really not looking at is the force and the timing on the implants. Okay. And I find this to be really important. If you think about the fact that, with the periodontal ligament, if we have 2 natural teeth and they're coming up and you're closing and they're opposing other natural teeth, right? So let's turn this molar to molar on its side. They come together and they touch. The minute they touch, they both start to recede, right? They both start to get compressed. Well, because they're getting compressed, it's like if you took a finger and poked me in the shoulder and pushed me. As long as I'm moving away, there's not a lot of pressure building up here. But the minute I seat and I stop moving and you keep pushing, now the pressure goes up. So what we can see in natural teeth coming together is, oh, they touched. It's nice and light blue, nice and light blue. Then it goes green, orange, red. When it goes green, orange, red, those natural teeth are fully seated because that pressure can't go up as long as the teeth are moving. Does that make sense? I explained that clearly? Tell me I didn't, because I don't want to confuse anybody. Okay. If you have an implant, that's just rigid. So it immediately loads when it touches. Right? So what we have found is that you can take an implant and you can use the T-scan so that your natural tooth is going to be just a bit higher and it's going to touch its opposing. It's going to settle. Then the force comes up on the natural tooth when the implant comes into contact. So now the implant's in contact, but it's not premature. If the implant touches before the surrounding teeth settle, then that implant's going to be high. And then you get things like bone loss, you get things like what do we call them? Remakes? Redos?
Well, Dr. Stevens would say that implants only fail for two reasons. I don't know if they can hear this.
Yeah.
The
Dr. Stevens would say implants fail for two reasons.
bugs or bite.
Bugs or bite. Yeah, that's true. That's true. He had a great article, which I will send to everybody. Was it Dental Economics or Dentistry Today? Showing loss of bone around an implant and showing that that implant was hitting at the same time as the natural surrounding teeth. And so he timed that implant and that's all he did. And the bone grew back in like 6 months, something like that. I mean, fascinating article. He's like, well, that's what it was. The bite was causing this implant to move in the bone, and that's what was causing the problem. Okay. No, he didn't do anything. It was purely an occlusal adjustment. Mm-hmm.
We put them in tight, but
Yep.
get them back to the expired. And 6 months later, right.
Mm-hmm.
Are you sure?
Well, the question was, does that explain open contacts on implants between natural teeth? And absolutely it can. Yeah, the microphone was pointing directly at me, unfortunately, so other questions don't get picked up. Let's go here. So when we look at long-term function of implant-supported full arch immediate load prosthesis, we've got a high complication rate, right?
I just remember inside dentistry.
Inside Dentistry was that article.
Where it was published.
Yep. We're going to skip the patient testimonials kind of things, but so why do we have occlusal complications despite all the digital advantages in dentistry, right? And one of the things that I found fascinating is, especially watching like your career from the lab side evolve, everything is digital from the beginning to the end, except for the actual end, which is the occlusion. That's sticking some paper, eyeball it, and go, yeah, it looks good, right? I mean, I find it really interesting that we can intraorally scan to a level of precision that's insane. And watching your team out here do the design work they do.
So we do our occlusion and our contacts in nanometers.
Yeah.
So, but
you do your occlusion and your contacts in nanometers. Yeah. That's fascinating. That's fascinating. However, what you do in the lab, what you don't have is the true 6 degree of freedom, actual movement of the mandible as it comes up into the maxilla. And that's one of the things that we're excited about with the things that we do, our joint vibration analysis, our EMG, our jaw tracking. Have you heard of ModJaw? It's a company that actually takes the intraoral scan, takes a photo of the face, takes the cone beam, 3D cone beam CT, and puts them all together, and then gives you motion. and gives you actual 6 degree of freedom jaw tracking. Really high. I mean, it's a $50,000 device. And you have to have all the other stuff, right, in order to make the picture go. But you literally have this 6 dimension vertical lateral AP movement, pitch, roll, and yaw of the mandible, watching how that mandible moves. And we were like, that's fascinating. That's super cool. Can you see how the joint's functioning or how the muscles are functioning? And they're like, no. It's like, do you want to put our EMG and JVA in your system? And they're like, yes. So now we're cooperating with them to put this whole system together. And I mean, ultimately someday where we want to get is to be able to design in nanometers, deliver in nanometers, and have it be physiologically perfect. Will we get there? We're going to try, right? But so we have all of this precision. And yet when we look at this, once we get to the end and we're looking at these contacts, we've got great occlusal rules, and we're not trying to say get rid of those. We're not trying to say ignore canine guidance or ignore, any of the rules of occlusion that you've been taught. It's just that you really can't see them in the mouth any other way. So leaves us with a lot of question marks. And you want to know things like, am I hitting too hard here? And I mean here, that dot. Not this one, or any of these really. Is this tooth loading first? There's an implant underneath there. This is a wide contact area here, but is that moderate force or is there a lot of force? Or is there very little force? Are you taking a lot of pressure here at maximum intercuspation? And being able to actually measure gets you to answer those questions. One of the things that we're going to do is we're going to have a real quick competition here. And this is for the people who are here, because I can't hear the people who aren't here, unfortunately. Okay. But we did 4 separate studies were done showing that doctors make a high percentage of errors, 90% wrong when it's talking about contacts and force levels. Okay. And it's simply because paper doesn't show it. So I have, and I'm not kidding, this is like the best. I got this coffee mug at a convention, and I had to go find the manufacturer because I went out at about 4 o'clock in the morning in Wisconsin, and it was like 20 degrees. And I put my coffee in my pocket, and I froze until about 2 in the afternoon. And I went, oh, I forgot my coffee. Damn. I popped it open, and it was still hot. So anyway, so we just put our logo. Okay. So we're going to have a little competition for the coffee mug. What I want you to do is take a look at these marks and tell me, actually write down what you think is the highest force. Which one? 1 through 9. And then pick the second highest force, 1 through 9. And if you think it's this one that's right next to 7 instead of the one that they circled, that's fine. Just pick the area 1, 2, 3, 4, 5, 6, 7, 8, 9 that you think has the highest force looking at the photographs.
We go around the room, or should we just let it? Maybe we should just.
Let me see what we have for time, because actually one of the things that we're at 7:25, so we're going to do live demos and let people play with the equipment. We won't draw out the competition. So highest, anybody pick 4? Anybody pick 9? Pick 9, because it's 4 and 9. 9 was your number 2? Okay, I'll give you the top of the coffee mug and I'll give you the bottom of the coffee mug. No. But that shows you right there. I mean, here we have, how many years of experience do we have in this room of looking at this stuff? And this isn't you're doing this wrong. It's the data's not there. It's like, what's the temperature outside? And I want you to tell me what the temperature is outside by looking at that whiteboard. Well, they have nothing to do with each other. Okay. You know, I mean, then that's, again, we're going to use this stuff, but to me, this is really exciting. But when you look, who gets the mug?
Yeah.
Actually, I have two mugs. They get the mugs. So you get a mug. You get a mug. Did I put the mug in? Could you? Thanks. So I'll bet you everybody watching online picked 4 and 9. That's probably what happened, right? But when you look at this, when we went through this and we went through multiple bites, multiple photos, out of 246 total choices, docs were right 4.88% of the time. That's to me that's mind-boggling.
That's when we rely so much on, oh, how does it feel?
How does it feel? Right. And I'm numb. What do you mean? How does it feel? You know, I mean, or
You just, yeah, that's the best you can do though.
oh no, 100%. Now, the other thing is, though, I find this really interesting, and this is something that's not uncommon. In fact, this exact same thing happened to my sister. Here is a patient who had a painful number 11 after crown number 13. So they put a crown on 13 and 11 became painful. Okay. So if we look at this, you see that high force right there on 11? Do you see that paper mark? Right there on 11? This was one of Robert Kirstein's patients. Huh? Here's the thing. Number one, we have high force, but do we have the high force spread out over a big area? Number one, it's on a tooth that doesn't have great root structure. It's designed to take a lot of that kind of force. But number two, look how small it is. Okay. I come from Wisconsin, from northern Wisconsin. You can go out on the frozen lake in January and I can pound my fist on the ice as hard as I can, and the ice isn't going to move. But if I have an ice pick in my hand and I use a third of the force, I'm not hitting it as hard as I can. I'm just doing this nice and light. And because I'm taking that little bit of force, but I'm concentrating in that little area, I'm going right through that stuff.
And that is why.
As a lab, you want us here and you want this shared. Right. And that's really what I find really satisfying is when we have doctors who have T-scan and they go, I had something I thought was just dust. Like that wasn't even a contact. I thought it was, you know, a complete mistake. But it kept saying there was a high force there. Go back and I look at the tooth. And it's like, well, that's there again. Let me just not even adjust it, but let's polish it. And the force goes down because you don't need a lot of tooth structure to deliver this kind of force, right?
That's when you usually tell a patient, well, it looks pretty good. Why don't you go home and
See if it gets better.
you'll get used to it.
Right. You'll grind it away, right? Yeah. That tooth will move. Don't worry about it. There's always Invisalign, right? So
You can't tell.
Yeah, but Dr. Stevens would also say sometimes a heavy polish just does the trick.
oh yeah, right. And it can. And we, you know, one of the things too that I want to make clear is that this isn't necessarily T-scan is showing you the force timing and balance, no different than JVA shows you how the joint is functioning. There's no reason you can't be additive, right? There's no reason you can't go, you know what? I don't want to reduce vertical dimension, because if you just go through and get rid of every contact that's the highest contact, you know what I mean? That's like saying, okay, out of this room of 1,000 people, I want the tallest one out the door. Hey, I said tallest one out the door. Hey, I said tallest, you know, eventually you're down to one person, you know, that's not what we're talking about. What we're talking about is trying to have bilateral, simultaneous and equal contacts all the way around. Okay, and that's what we see in really healthy and really stable occlusions. One of the big applications for this is orthodontics. When someone is done with ortho, and it doesn't matter if it's straight wire, it doesn't matter if it's clear aligners, right? We've now created a whole new occlusion. Some of our clients go, take everything off, bite. Let's start adjusting the big stuff. Let's start balancing this occlusion right away. Other doctors follow the older orthodontic model of give it a couple of weeks. Let's let you settle in, right? What I can share with you is my sister, she's not watching this, so I can talk about her, is in her third set of Invisalign. And I show up to a family dinner and I go, you're done? Yep, bite on this. I'm like, you're screwed up and you are completely going to relapse. And she says, shut up. Because I'm her dumb big brother. And she relapsed the way I said. And so then she did it again. And she thinks Invisalign, that Invisalign doctor didn't know what he's doing. And that Invisalign doctor didn't know what he's doing. But this one, I think, knows what he's doing. You know, and it's like, no, you don't. Okay, fine. I love you very much. And you have cute children. So we're not going to talk about this anymore. But I mean, the point is that, you know, there's forces. What moves teeth in ortho? Forces. That's it. And so when you're done with ortho, what are the forces? Is your tongue providing the right kind of support for your arch that it should? Is your face providing the right kind of contraction that it should? And are the forces going through the teeth in the direction and in the distribution that they should be? If you have that, boom, you're stable. If there aren't forces to move the teeth aren't going to move. They won't. Okay. So, research study by actually a good friend of mine, Sarah Kadir, essentially just says that the accuracy and reliability of T-scan compared to static paper is really great. This is what I'm talking about. We will not have time to get into this, but I will talk after this about how we do this, and it's called disclusion time reduction. Okay, what we were talking about earlier today, and I've got a follow-up course from Dr. Kirsty and Dr. Ben Sutter, who do actually treat patients with this. I'm not a doctor, but they are. That we're going to get that information to if you want to learn about this more. Okay. This is patient. Watch her eyes. This is ice water. How does that feel? Did you see her eyebrows?
It's only 7 or 8. It's pretty.
Good.
Especially with the beauty.
All right, so then they go to do the adjustments. Oh,
Take a mouthful of water. Good.
Especially with the beauty.
but it's a second fade. It's all in one. Ten minutes later, you can see the ice in the water.
Like cold. Pain. 2, 1.
Now, the theory behind this is that in disclusion movements, and with disclusion, I'm not talking about opening, I'm talking about lateral excursions left and right. Okay. That if in your lateral disclusion, you should have guidance on the side that you're going to, and you should immediately disclude from the side you're moving away from. Okay. So if I'm moving teeth together, left to right, my right side, right to left, my right side should immediately, within 20 milliseconds, disclude and come apart. The teeth are no longer touching because I'm being guided by the side that I'm moving towards. If I move to the right, I should be guiding here and immediately disclude on the left. And so one of the really great founding researchers in this, Robert Kirstein, found that patients who discluded their non-working side discluded within 20 milliseconds, that had an incredibly low rate of headaches and cold sensitivity and tooth pain. So he started saying, in addition to making sure that you occlude the way you should, I want to make sure you disclude to this quick level where the non-working side immediately discludes. Okay. In other words, I'm going to reduce the disclusion time. So disclusion time reduction. A lot of patients got better. Some patients didn't. And it was a fair amount. It was about 80-20. But what he found is that some patients, if he'd get that disclusion time down to 10 milliseconds, then they'd get better. And in the 90s, he and my business partner were talking and came up with the idea that, well, this is not really the teeth, but rather the trigeminal nerve and the muscles working together. Maybe if we looked at the muscles and disclusion simultaneously. So what we did is we combined, that's how we ended up working with TechScan. We combined our electromyography with the T-scan. And now what we see is that 20 millisecond is a good number, but what you want to do is you want to get the opposite side to disclude and the muscles turn off. And then that's the proper amount of disclusion time, if that makes sense. And I'll show that to you. But what we found is that if you have a patient with cold sensitivity to the point where swishing ice water is painful, 6 or higher, shouldn't be. Almost invariably, they'll have long disclusion time. And when they slide to one side, you'll see the muscles continuing to struggle when they should be relaxing. Okay. So this part of the slide presentation just goes into showing that your digital contact design with your scanners, it doesn't show, it shows if you put them together the way the scanner says to put together, and you put them together with the theoretic force, this is where the contacts and where the forces would be, but that has nothing to do with what the actual forces are in the patient. So this is just showing that T-scan actually shows different than what those scanner things do. So I just think intraoral scanners are so useful. It doesn't matter if they don't show this. I can't imagine doing dentistry without one. All right. But what we're focusing on, what you're doing, Scott, is the macro occlusion, right? And then we go to the T-scan and we're looking at the micro occlusion. We're looking at the force and the timing and the balance.
We don't have a period.
Right. No, that's it. You don't have the periodontal ligament. Exactly. All right. So let's take a look here. This is where we've taken the STL file from the patient and dropped it in. Okay. So you see with this tail, when this patient first started hitting, they're hitting all up here in the front, but then as they come into maximum intercuspation, everything kind of settles back here. And this is the bite that we end up with. These are all implants where we have our highest force. 18% on 3. What does that say? 10%. And 28% here on 14, which is an implant. Okay. Now, once we do our T-scan implant guided adjustment, now what we have is we don't have those high forces on those teeth, right? So we've been able to go in and kind of adjust that. We still have good balance. That center of force icon is still in the center of the arch. And this is just that comparing that pre to that post.
How long did that take, do you think, to do that?
It's one appointment.
Yeah. Think it, like, is that a 30-minute visit or an hour visit? What is that convenient?
Well, a T-scan occlusal visit typically does take more time because you're adjusting and you're looking and you're adjusting and you're looking, but you're also done. How long this particular case took, I don't know. You know, and I don't want to be, you know, you and I talked about this being educational. This is what can be done. But because now you can see something you could never see before, right? You run in the woods quite a bit, right? Do you have your eyes closed when you do it? Because that's how I do it, and I don't like running in the woods. Right? But the minute you can see, running in the woods can be quite pleasurable. I mean, that's the whole point here, is you're seeing the things that impact your dentistry, that impact your patient, that impact the health of your patient's stomatognathic system, and by seeing it, you can control it. Now, go ahead.
So with the T-scan, can you do anything with protrusive, lateral intrusive? Can you find?
Oh, yeah, for sure. For sure. And we'll actually do that. So you can do like, okay, what is my anterior guidance? Well, do I have canine guidance? All of that kind of stuff. And that is really where the whole nathologic family comes and says, okay, these are what the rules of occlusion are. Do you have what I want you to have? And if you don't have canine guidance, what do? We build up the canine, right? You're not going to grind the molars down until the canines come into contact, right? So there's T-scan additive and there's T-scan subtractive. Okay. Now, so we're talking about implant insertions. This is a research project that I really wanted to share. It just got published not too long ago. And Henrietta Lerner in Germany is the one who led it. But essentially what they did was she does a ton of implants. And they had 143 implants that were installed and adjusted with articulating paper only. And all these doctors were co-trained, worked together, equal experience. And they did 163 units installed and did T-scan and articulating paper. Both groups were calculated to be statistically significant or statistically similar. But when you look at the complications over 3 years, you see we had 35 complications, paper only, and 3 with T-scan and paper. But the one that gets me is screws loosening and prosthesis mobility was 21-1. That's huge. I mean, that's huge. That's huge to the point, oh, you had that problem? Show me your T-scan. Did you adjust this right? Because if you didn't adjust it right, why am I giving you a deal on doing it again? Because you didn't do your...
Yeah, you know what's interesting, from a lab point of view, the question we get on.
Do me a favor, could you come over here and say that? Because from a lab point of view is important. No, because it matters. It really does. You're such a valuable resource to these doctors.
From the lab view, one of the most significant problems we have is the screw loosening. And doctors will ask, did you use an off-label screw? Is this a screw that's not OEM? And that's the question we get all the time. So we have to, we record everything. Like what is put in, when it was put in, and by whom it was put in.
What hardware store you bought?
Exactly. So everything has to be recorded so we can go back and have proof that we did this, because that question comes up constantly. And again, this is why we think if there was a tool, there's got to be a way to show that it's not just lab. Do we mess up? Yes, we do. Absolutely. We're not perfect. But I don't think of all the phone calls that happen through a year, certainly it's not the lab all the time.
What I do a lot is lecture on JVA, EMG, our jaw tracker. I do some T-scan. I focus a lot on the laser. T-scan is probably the thing I lecture on the least, just because we have so many dentists that lecture about it and so many other people that just do it more than I do. And sitting here today, looking at this, I read this article and I actually was in Cologne when Henrietta, it was at an IDS meeting where she had the idea to do this course, do this research project. And so I've been familiar with this coming out. When the paper came out, I read it. But that 21-1 struck me like 2 hours ago sitting here.
It's actually 26-1, because there's 3 other categories, combination categories that are on school list.
She just asked a really great question.
Okay.
She asked me, is it higher on angled screw channels? Off angle access screws? And that is yes by double.
Yeah. Yeah. Is it higher on off angle?
Yep. It is.
You're talking about an off angle.
Screw channel.
Screw channel.
Yes, 15 degree.
Yeah,
Well, the other issue with an incline contact on an implant.
yeah,
You're gonna get.
yeah,
Vibrations.
right. Well, what in bridge construction, if you have any of that kind of angular kind of problems with the support beams, you see all the cement fleck off the opposite side. So if you're getting pressure this way in one of those supports, you get abfractions on the supports of a bridge.
Well, I think I don't know what exactly. I don't know if this is correct. But the lines of Luder, those little like fractions,
Mhm.
by the cervical neck, is caused by that very thing.
Yes. Yeah, and so that's just right there, that just, guides you in that, but you're right, it is 26-1, if you do the math. I mean, that's powerful. That's really. So the complication rate for articulating paper was 24.5%. And for T-scan and articulating paper, 1.8%. So Scott, could I borrow you for a moment? Again, because I want them to hear. Financially, if you can change your failure rate from 24.5% to 10%, how much money is that saving?
Well, it's not just it's not the lab, but it's also the satisfaction of the patient,
Mm-hmm.
and then the time in the chair is through the roof.
Mm-hmm.
Yes, there is a money savings for the lab, there's no doubt.
Mm-hmm.
But for the doctor, it's 10,
Mm-hmm.
right
And
now, if you think of a crown, it's about 10% of what the cost is to the patient.
Mhm. If you call bio research, you'll likely get one of us, but over time, at some point, you'll talk to Angela Haberman. She is our director of operations. Every year in January, we do our annual meeting, and it's a vacation meeting, but it's very serious CE. This year, we're doing it at the Hard Rock in Cancun. We do a solid 7 hours of hard lecture, and then we go to the pool. But what's cool is you're surrounded by dentists that are doing all of this in their own little towns, that are doing this higher level dentistry stuff. And how do you do that in Tukwila, Washington? How do you do this in Two Rivers, Wisconsin? Well, this is what I do, and this is how and I get people from all, you know what I mean? And you share the things that I have a staff member who doesn't want to. What do you, how would you deal with, that kind, all that stuff, because they're in your world. So we send Angie to this, and she meets all the people, and everything's wonderful. And she comes back, and on Monday, after going to Cancun last year, she goes, I have to go see my dentist. My tooth has been killing me for 2 weeks. I'm like, why didn't you say something? Because she worked her butt off at this course, right? And she goes, well, no, it's no big deal. I just got a crown and it's been killing me ever since. Again, why didn't you say something? We're kind of in the biz. Come here, bite on this. 35% of her bite force is on the crown. And she said, well, he said it was fine. I said, I'll make a movie, go back, and what have you. And he went, oh yeah, you're right. And adjusted it based on the movie that I sent him. And she came back and she goes, yes, it feels way better now. Okay, well, good. I'm glad. 2 weeks ago, she says, I'm going to get another crown. I go, from that same guy? She goes, oh no, he's an idiot. He doesn't know what he's doing. That was her. That's what she walked away from. She's not in dentistry. She's in operations. You know what I mean? She does our finances and our inventory and all that. She doesn't know really anything about what we do or the clinical side of it, which is why when her tooth hurt, she went to a dentist. She didn't even once think to talk to us. You know, it's like you have all this free. Very embarrassing story. I crack 14. I go to see Chris Stevens, who lectured on this equipment for 20 years. He does buddy dentistry, literally has food in the op while he's putting the crown in 14 for me. Because it's cheap that way, right? And he says, you want me to T-scan that? I went, no, I got to get back to the office. And that night, my crown is killing me. And I had 64% of my bite force on that crown. Well, no wonder it was killing me. So the next day I call him, and you know, in Chris Stevens fashion, I won't use the words, but he goes, well, did you use a T-scan? No. Well, then you should. So I bite on it, and as hard as I could bite, I got to 68. I can't bite any harder than that. He said, come in. So then I drove over, sip, sip, sip. Everything was fine immediately. And it was just and it was maybe a 10-minute appointment. Number one, we knew what tooth we were dealing with. It was just replacement dentistry. But I don't know, and I don't know, because I'm not a dentist, but I don't know, was it the cement? Was it the design of the crown? I don't know. But the minute he bit, looked at the paper, that's the problem.
No, it was a crappy lab.
Very well could have been.
It was us.
It was you.
Yeah, we did.
Yeah, that was.
Yeah.
That was you. I didn't want to say that, but yeah.
We have to up our game.
Yeah.
Question for you, unless some people in the room, so your discussion about cold sensitivity.
Yeah.
With eccentric interferences, what do you see as the mechanism of that situation? My question is more to the point of an immediate relief of cold sensitivity
Mm-hmm.
from occlusal reduction.
Mm-hmm.
What do you see? as
Immediate and lasting. That's the thing. Because it's not like when you have muscle spasms and you put something between the teeth. Like a lot of the muscle.
Repeat the question.
Okay.
So it's not like hypersensitive dentin from toothbrush.
It's not hypersensitive dentin from toothbrush. No. I'm gonna get this wrong. I'll get this corrected and answer it. But what you're asking is, what is the mechanism that is affected by disclusion time reduction that reduces that cold sensitivity immediately and long term? Like it just doesn't come back. Okay. And as I understand it, it is that lateral forces essentially create a nociceptive input to the nerve that makes them, for lack of a better term, hypersensitive to all stimulus, right? You get me on 4 hours of sleep and no coffee, I'm a cranky guy, right? But if you let me calm down, let me rest, I'm a very casual guy, right? And I mean, that's the analogy that I can get. What I will do is I will get for you the official hypothesis. It hasn't been proven, but what's really interesting is this is very, very, very repeatable. You have a patient, think of the patients that you have, and you know, if you don't have a T-scan, we'll look for someone in the area that does, and let's get that done because it's impressive.
So if it's cold sensitivity, it's usually a lab.
Almost always a lateral disclusion time interference. In other words, I'll show that here real quick, actually.
It's getting,
Mm-hmm.
if you were a swimmer, you.
Right. A lot like that, yes. Let me get to this. This is hey, no worries. It was very nice meeting you.
Chase.
Hey, good to see you.
Thank you for having me.
So what we're gonna do here is we are going to. All right, so this is the disclusion time reduction stuff. And this is where what we did was we actually combined our electromyography with T-scan. So you're gonna see one other piece of equipment in here. I want to show you how it works because I know that we are running tight on time. So what we do is we combine our electromyography, which records muscle activity, and the T-scan, and we combine them to record them and display them at the exact same time. Okay? And so what you see is we have the patient actually bite in maximum intercuspation, and now this patient is sliding to the right. And you see how on the left they're holding on and holding on and holding on down here? Right? That's not letting go. And you can see that the temporalis right is continuing to fire and continuing to fire and continuing to fire. Because as this patient goes to, and I'm going to back this up to the beginning. In our T-scan, this is our arch, this is our 3D arch. Down here is that power, okay? And remember in the beginning, I said A to B is occlusion time. A is first tooth contact. B is 90% of maximum intercuspation. Once you're there, you're considered occluded. Yeah, you might go another 10%, but we figured 90 is good. Once you start to disclude, this black is total power. We're at 100%. Now I've relaxed a little bit. That kicks off C. C is the beginning of disclusion. So what we do, the way that we record this, is we have you bite on the T-scan sensor, and I say, I want you to bite hard, maximum intercuspation, and with your teeth together, slide your jaw all the way to one side. Don't separate your teeth and come over, but teeth together all the way out, because I want to see what that guidance is. Okay, so let's go ahead and bite and slide. And with this patient, what we saw was this is bite, and now they're sliding. And you see this little gray line. This is where we are live, and this is what the muscles are doing. You see that right temporalis. There's two different ways to see it, this piston and this graph. But that muscle is not giving up, and that non-working side is not letting go. So what do? We go and we look in the mouth at that contact. We take the paper. We have you slide the same way. Now we see the trace of where that is. We're not reducing vertical dimension. We're freeing you to go left, right. You're not going to change this patient's vertical dimension at all. They're not actually, their bite's not going to get deeper. This is just freeing left, right movement. Okay. Yes. So we have a very long disclusion time. You see how long it took us in time to get from C to D. Now, this is with the excursive friction removed, markedly lessens hyperactivity and removes muscular TMD symptoms. All you have to do here is look at this line and look at how much steeper and shorter it is to get from C to D. That's really all we're looking at. And so this is the exact same thing. This is where that excursive, where it wouldn't let go. It's not there. Everything is released. And what would that be? If we look right here, right, that's canine guidance. Watch what happens on the canine as they're sliding right. All of this is gone. All this goes away, and that's canine guidance. And so by getting rid of, so, you think back, oh, this person has great 30, 40, 50 years ago when L.D. Pankey and Peter Dawson were talking about canine guidance. If you had canine guidance, you didn't have long disclusion time. But if you have long disclusion time, like I have terribly long disclusion time. And what's interesting going through ortho is every now and then I get headaches. I've never had a non-alcohol or fist-related headache in my life. College days, not recently. But I mean, I'd never get headaches. And now that I'm in ortho, every now and then I have a headache for a week. And my feet feel weird. But then my teeth keep moving and then that goes away. And that is just that changing of the occlusion as I'm going through ortho. But right here, we can see very clearly how being able to control occlusion in your practice and disclusion in your practice impacts your practice. Whether you're doing, yeah.
Greg, I don't mean to rush you by no means.
Rush me.
We have 20 minutes and I want to make sure that we do the hands-on.
Hands-on, sure. Well, let's let's do one. I mean, I don't have, there's a lot of research slides to go through. Do you know what I mean? And things like that this is predictable and going through the research. But I think that we can get to, and that I can share with you, and you can read as much as you want. I would much rather do a JVA, do a T-scan on someone and have a conversation about where you are, and then do another one. You know, does anybody want to be the guinea pig or the test patient? You'll do it? All right.
Find some mountains.
Yeah, go right ahead. Go right ahead. All right, we're gonna take a 5-minute break and we're gonna be right back and do some live traces. I should probably get a new sensor.
Depends on how
Wipe
big
this
you are.
one off on my paint.
The cost of a T scan and those inserts.
T-scan is
Uh,
normally 12,000. Through Epic, it's 10,900.
Yeah,
Well, not through Epic, but if
But-
you're here because of Epic, you reach out to BioResearch, it's 10,900. The sensors are, depending on the quantity that you buy them in, $8 to $9 a piece. What we do recommend is until you bite through one, it's not done. So just get one of those accordion folders. What's the patient's name? Wipe it down, throw it back in. You can use it in 6 months. You can use it in a year. You can use it in 2 years. What you'll see is if the sensor is ruined, without it in the mouth, there'll be a pin. There'll be a point like it's being bitten on because you poked a hole through it.
yeah.
Until that happens, that sensor, you can keep using that thing. It depends on the steepness and the sharpness of the cusps. Some patients, it's 15 bites. Some patients, it's 60 bites. You know, we have doctors that will use it in hygiene and do nothing but go, this just shows us the forces in your arch. And the patient sees, wow, everything's on the right side. Is that normal? No, that isn't. But that's a lot more comprehensive dentistry, which we do, because there are patients who are like my father, which was I go to the dentist to have a tooth pulled, and I go to the doctor to not die. And then we have patients like me, which is this could be a problem. I should start looking now. I mean, my dad had his first heart attack at 50. I started getting heart scans at 30, and my heart's perfect. And the minute my doctor says, "Hey, your blood pressure's a little," okay, what do I do? How do I fix that? And it's how proactive are they in all of this? So
Scott's already diagnosed it. He said the shoemaker needs new shoes.
that's a good.
So, lateral open bite, eccentric interference, you'll see it. Yeah.
So what we're going to do is we're going to let me see the arch. Okay,
Medium narrow.
I was gonna say medium middle, yeah. Now with the T-scan arches, we have large and small, and I think with you, we're gonna go with the large. Better too big than too small. Have you do. This is going in, that's a small.
Was that?
Whatever.
Yeah.
So can you design your? Or. When a crown?
Absolutely, yes, we do. We do. Unless you say otherwise. Yeah. It's a default setting that we have on all endpoints. Mhm. Great question.
All right,
It's off out of the way.
sure. So what we're gonna have you do is I'm gonna put this in the corner of your mouth, and if you can just kind of pull your cheek out of the way, we can get that in there.
Want some gloves?
There we go. I would think I'll be okay, because I'm not gonna be
Okay.
going in. I want you to bite down hard. And relax. Now, what I'm doing right now is I'm just adjusting the sensitivity. Bite down hard and relax. There, I got what I want. Now we're gonna take one. We're just gonna take what we call a multi-bite. I'm gonna have them bite down hard and relax, and then bite down hard and relax, okay? All right, hold on. We're gonna start now. Bite down hard, hard, and relax. Bite down hard, hard, and relax. And so there's our first recording, which is what we call the multi-bite, okay? Now what we're gonna do is we're going to say, we're gonna take another trace. I want you to bite down as hard as you can, but keeping your teeth in contact, slide your jaw all the way out to your left. So bite down as hard as you can and slide your jaw, just your lower jaw, all the way out to your left. And as silly as that is, doing all the way out to your left and giving them a tap, otherwise, I don't know which way their jaw should go. I don't know why that is, but
Most
it
of them,
is.
you'd move their whole head.
Well, that is true, yes, and we don't want you to turn your head, right? Okay, so again, we're gonna go same deal. Pull your cheek out a bit, get that in there. Bite down hard, and slide all the way out to the left. Slide. Okay. All right, that took me a bit there. Let's see if I got it. Nope, sorry, that was a recording error on my part. Do one more. Oops, sorry. There we go. There we go. Bite down hard, slide all the way out, teeth together to the left, as far as you can, and perfect. All right, so that's the left. Now we're gonna do the right. Give me a second. Bite down hard as you can, and all the way to the right. Out, and good. Okay.
So 11 shows up, or 6.
Switch down here. No. It's all right. There's room for
I've
two.
been sitting all day.
Yeah. All right, so first we're gonna look at this multi-bite. And what I will typically do is I will look at the patient, teeth coming in, and I like to take this view and just kind of tip it up like that. So we've got our light blue contacts, so the teeth are just touching and they're all settling.
This is right, left.
This is right, this is left, this is right, and this is left. All right, and now we start to see the forces come in. And this is actually really good, because what are we seeing? We're seeing everything kind of rise up together, right? There's always going to be a leader. It's not like you got to chop that off, right? But this is really good bilateral coming in. Okay,
Yeah,
a little high, but you're always gonna have the tallest man in the room. We were talking about that before, right? So the presence of pinks, it's not like I have to get rid of all those. That's not what we're doing. We're trying to look at the general layout. One thing that we do notice though is look at that center of force, both its tail and where it is. It starts left, it stays left. It moves a little posterior, but it is definitely shifted off to the left. Okay, so he's got 55-45 balance right left. That's not terrible. Okay.
So you look in the mouth and you see the upper action erosion on the upper right.
Oh yeah, really? So now Gotcha. So now,
Forces me left.
oh, okay. And that's why you left. Okay. Yeah. Well, and again, this gives you information you can't see any other way. That's information you get
By looking at.
by looking in the mouth.
By staring at down the teeth in
Mhm.
somebody's mouth for how many years?
Exactly. Exactly. So now we're going to look at disclusion to the left. And just looking at the distance from C to D, do you think this right side is going to release right away? Because now we're going to watch him disclude.
Distance, well, what are you looking at?
What you're going to do is, this is you at maximum intercuspation, okay? And now this recording was you sliding to the left, okay? And what I'm thinking is that these contacts, you're gonna get to canine guidance, but these contacts are gonna hang on a lot longer than they should. And so when you slide to the left, and I keep going through, yeah, they hang on for a little bit, and then we're out here where we should be. You know, you're moving in the right direction. This isn't terrible, but it does take quite a bit. And then if we take a look at the disclusion time to the right, here we are, maximum intercuspation, and he's sliding out and to the right, and continuing out and to the right. And look at this right here. As he's sliding out and to the right, look what happens here. Okay, all that power comes down, and then you come up across something else.
14 DL cusp.
And there you come across something else.
Yeah.
Yep. Now there you were, I think you were just backbiting again, you know. But the whole idea there is now we can see, how do you come into occlusion and how do you come out of occlusion, and we can control it.
Interesting.
And that's really what T-scan is all about. You know, JVA for stabilizing the skeletal base, T-scan for stabilizing the bite. And if you're stable in the beginning and you're stable at the end, you should stay stable. Because what else is going to move things other than trauma? Bugs.
I got a question for you. What about these people who are completely in a artificial bite relationship that is not driven by the joint? For example, somebody has an anterior crossbite on number 10, and you unlock that anterior crossbite, and all of a sudden now you see that whole mandible little chunk into a class 2 deep bite. And they've been functioning out here artificially for years. Is that going to show up with, you're looking at just bite relationships here?
Right.
You're not seeing anything joint related.
No, no, not with the T-scan. That's specifically what we had talked about earlier was joint vibration analysis for looking at joint function. Because what you'll see there, when they fall back like that, very often you'll see displacement. You know, because all of a sudden everything falls back and they're in a class 2 relationship.
We're looking at the bomb site here with regard to the, the pattern. What is that giving you in terms of calculations? That's just giving you center of force.
That is just giving you center of force. That's exactly what that green, or sorry, white and red square is the center of force at this point. And so what this is a trail of all of the center of forces. So you'll see the minute the teeth start coming together significantly, that's where your center of force starts as you were occluding. Okay. And you're coming into your bite, and now it's just leaving a trail of where the center of force was. You're coming in, so you move a little bit left, and then you come back and you move a little bit back, and now you're at maximum intercuspation. And as we're there, you kind of sit in one spot.
Which is not great. You really don't want that mandible to be forced back when you're going into MR.
Correct, and that's exactly what's happening with you. So that this is something that in the T-scan course,
back?
well, it's being forced back by right there. That's where the force is, and that's what it's doing. Yeah, and as those are coming in, you're moving back, and then this comes up. Right. And so that's what you would address for coming into occlusion.
Mhm.
So that you seat where you should, and then how do you get out of there? And you have to do occlusion first. Because if you do disclusion first, and then you do occlusion, now you're in a different spot, so you're gonna disclude different. You know what I mean? So there is an order to all of this, and so that's the reason I say the first thing we want is bilateral even contacts coming in. Okay, you seat well. How do you get out to the left? How do you get out to the right?
As quickly as possible.
As quickly as possible.
The one thing that this wouldn't show me, and you would look at as a clinician, is you're gonna look at wear patterns on teeth, and especially with older folks, you're not gonna see them so much on these kids. But I'm heavy on 10-11 over here, but the reason I'm heavy on 10-11 is because I'm narrowing almost end to end on the right, on the bias.
Mm-hmm,
Vertical, and that creates a lot of work, that's forcing me to the other side.
mm-hmm, mm-hmm.
I think that's key though.
That's clinical stuff.
I think that's
Yeah.
key though, but, cause if you need to be able to know the signs and symptoms.
I mean, this is great to see this, but you have to put together the clinical pattern and some.
Right.
Yeah, and
expertise as well.
that's actually a great point,
I mean,
because
you can't just go by the numbers.
no,
Exactly.
and there are doctors out there that give courses that have built up their
Portfolio.
yeah, talking about this equipment, like stuff I sell. And it's like, man, this stuff diagnoses. No, it doesn't. None of our equipment diagnoses anything. Everything that we do is a diagnostic aid. It gives you information to look at, not in a vacuum, but in addition to all the other things.
Yeah.
Oh, you're going through chemo? No, I mean, seriously, I mean, those kind of things have a huge impact on the mouth. You know, I mean, you still have to
Dr.
take
Chris
in,
Stevens used to talk about, this is really key to him. Because if you have a patient who has no signs, but has symptoms,
Mhm.
then that's a different person that has signs and symptoms.
Sure,
You have to decide whether you're going to proceed with treatment or say goodbye.
Mhm.
But if you don't know what those signs and symptoms are, then this means kind of like nothing.
Right. Well, and that's where we really got we are now moving beyond just TMD and craniofacial pain, and that's why we're here, right? That's why we're here in the restorative, in the implant world, and talking to doctors whose focus may not be 100% craniofacial pain. But in a 100% craniofacial pain, the TMD specialists, what I'm very proud of is that I have clients who will look at their patients clinically and say, well, I have clicking and I have terrible headaches and my neck hurts and da da da. Okay. JVA, look at the joint. Yeah, there's a click there, but that thing is so small. This is not the problem. Yes, you have clicking, and yes, you have craniofacial pain, which is pain between here and here. But that click is not going to be doing that. And let me look at your muscles. Hey, they're resting properly. And your clench is nice and bilaterally balanced, you know, and your swallow is good. And let's take a look at your occlusion. And you have bilateral simultaneous even loading, and your disclusion time is not bad. You have craniofacial pain, but you don't have anything I treat. Because what causes craniofacial pain? Joint problems, muscle problems, teeth problems, eye problems, ear problems, sinus problems, tumors, stress, colds, children, ex-wives, trauma. No, but I mean, it's circulatory issues in the brain. None of this helps that. But if you're not going to treat that patient, you don't have any of the signs, you have symptoms. I can treat you symptomatically.
This is
Right.
exactly what I'm talking about.
Right. I can treat your symptoms. I can make you pain-free. We drove through a neighborhood, those people could make us pain-free. Isn't going to solve the problem. Right. So, you know, for me, the big issue is trying to give you that vision into the patient's physiology of what can you impact. And then when you do it, do you see the results? You know, and then again, none of this is ever going to be you're going to fix everybody, but it gives you a much higher standard of care and a standard of control than you have any other way.
So it is 8:30.
Yeah.
We're supposed to leave.
No, my pleasure. Thank you.
You want to give a quick wrap up or talk about the course?
Well, yeah, there are a couple of courses that are coming up that what I'm going to do, because you registered, I've got your email. We're not going to blast you. We're not going to spam you with a bunch of stuff, any of that. However, what you will get from me is you will get a email early next week. Monday's Labor Day, right? Okay, so it'll be middle of next week. You'll get an email saying, here's your form for your 2.5 hours of CE. Fill that out, send that in. Also, you will get a link to a special registration for the disclusion time reduction course that's coming up. It's late, I don't have the dates. It's, I believe, late September, early October at UNLV. It's given throughout the year, but you'll get the link to the people who give that. You will also get a invitation to our biometric integration course. We have a 2-day course on integrating biometrics like this into your practice. It does teach you how to use them, but it's also much more when you bring in CBCT, when you bring in something revolutionary, how do you get your team to incorporate it and onboard it? How do you properly train them, right? So it's making sure that when you make an investment of 12 grand for the T-scanner, 13 for JVA, you have that new user experience that is amazing, right? Because to me, it's more important that you get great results. And then you'll also get an invitation to our course in Cancun. And that course covers a lot of ground. It covers sleep apnea, covers orthodontics, covers orthodontics twice, covers laser therapy for craniofacial pain, covers joint treatments. And that is again at the Hard Rock in Cancun, January 16, 17, and 18. Normally, the tuition for that course is $3,800. It includes your stay, double occupancy, all inclusive, which is $2,300. And I believe for the Epic people, we're charging $32. So really, the course is costing you like $900 and your stay. January 16th through the 18th, I want to believe. Are you really? We'll just stay then. We'll throw on a couple of days. Well, that's the point. I mean, really, the whole point is that our courses, and Scott, you can attest to this coming to our annual meeting for years, right? Our courses, we used to give them in Milwaukee. And it was fantastic because it was our hometown and we did it downtown and everything. Milwaukee's not as safe as it used to be. So we decided maybe we go somewhere else.
I imagine Cancun again.
Cancun, well, it depends on how many snowmobiles you own. Milwaukee can be pretty nice in January if you have a lot of snowmobiles. But other than that, it's not a lot of fun. But what I thought was when we went to Cancun, or like we used to do Punta Cana, that it would be one of those deals where everybody rolls in at like 10:30, kind of hungover and sunburned, and course goes till 2:30 or 3, and everyone's sneaking out early. Everyone's in early. Everyone stays till the end. Everybody sticks together. I mean, it really is just because it's all these dentists who are really enjoying sharing and getting to know each other and building those connections and those, that kind of sort of professional level friendships. And that's something we've been able to maintain. I was worried about going to a vacation spot. I really didn't want to do it.
I'm gonna convince you to go to Bermuda next time.
Okay. Twist my arm. We'd like to go somewhere new every year. We went to a different resort in Cancun last year, and it was great. But we just a lot of people wanted the Hard Rock this year. So
Well, we appreciate you coming. It means a lot.
well, I appreciate you spending your time, spending your evenings. That's valuable. I know.
And we'll be following up with you, so.
Yeah, absolutely. Greg K at bioresearchinc.com if you have any questions. If there's anything I forget to send you, but I'll get all that out first thing on Tuesday.
I have these two meals too. Anyone who.
Thank you all for coming.
I sent you an email already, because you said earlier that you get for research. Yeah.
Oh, good. Good, absolutely. I will get that out. We'll get the, and you know, the other things that I'll do is I will send you, there's 4 or 5, there, 2 of them lecture a lot. 3 of them. I'll send you some clinicians that are, yeah, I'll talk to anybody. And they're not sales reps, they're not employed by us, but they've like, wow, this really has had a massive impact in my practice. And as a non-dentist, I can only give you so much real world info. You know what I mean? I'm not boots on the ground, you know, I'm in the building that makes the tools. So, but no, it's been I appreciate you guys being here. Sincerely. I'm Greg, by the way. Nick, nice to meet you, Nick. David. Hamilton? As soon as you, right, exactly. Exactly. I think you were given it. You were given it. Oh, yeah. Yeah, feel bad. Actually, you can take these.
No. Hey, make sure you get your hat. Oh, thank you. Does anybody want these extra meals? Dick.
Censored. Obviously.
Oh, man, I'll bring it to Zach.
They are. That's easy.
Let's go for 4 meals.
And $9 a piece.
Football practice.
Well, 8 to 9. But you don't have to throw them away. You can just stick them down over handicaps. Put them in an envelope with the patient's name, throw them out the bag. As long as you don't.
We do it for them too.
And you'll know.
You're good.
Because what will happen is
Yeah, thank you.
without it in the patient's mouth,
Good.
like it's not in the patient's mouth, you'll see that, oh, it's broken. That's it. It's that simple. I'm gonna run and use the restroom real quick.
Thank you.
I'm not trying to bum rush you out.
Thank you. So appreciate it. Get the. Part very. Hey. What is? Hear your feedback? Yeah.
I don't think so.
All positive here. All positive here. Excellent. Everything the donut shaped. Excessive occlusal contact has been shaken. Goodbye, T skin. Fantastic.